Hi guys, so welcome back. I'm going to continue the lesson that I was doing on the endocrine system. I've already covered diabetes type 1 and 2. I've covered the insulins. I've covered the thyroids and parathyroids. So this actually is a part 3, but technically a part 2. Anyway, guys, let's get started. Let me share my screen. Once I remember how to share my screen, give me a second, guys. All right, there we go. Wonderful. All right, so last video when I was going over this, I talked about the most important way that you can measure a patient's fluid status, and it's always going to be daily weight. It's not going to be skin turgor. It's not going to be INO. It's daily weight. So this is where I left off last time. So I'm going to start with hypovolemia. Whenever we're talking about hypovolemia or hypervolemia, we're talking about fluid status within the vessel. And this is where students get confused because you hear hypovolemia, a little bit of fluid, or hypervolemia, too much fluid. And for example, when you hear hypervolemia, you think too much fluid, you think the patient's going to be all swollen. But remember, we're not talking about fluid in the tissues. We're talking about fluid within the vessel. So let's start with this right here, hypovolemia. Not enough fluid where? In the vessel. So that patient's going to be dehydrated. Signs and symptoms of hypovolemia: when that patient's dehydrated, they're going to have increased temperature. They're going to have a very rapid but weak pulse. Why? I want you to think about it. That pulse is going to be weak because there's no fluid volume, right? But it's rapid because the heart's trying to compensate. The heart's trying to push out fluid and blood that just is non-existent. That's why that patient's going to have a rapid but a weak pulse. Tachycardia, increased respirations, hypotension, blood pressure is going to be down because remember, what is blood pressure? Blood pressure is just that force that's being exerted against the vessel. So if there's not much fluid, there's not going to be much force, the blood pressure is going to be low. Patient's going to have anxiety. The urine specific gravity is going to be high. And I want you to think of urine specific gravity. I want you to think of solutes that's in the urine. The more solutes you have in the urine, such as, sodium and electrolytes, the heavier that urine is going to be. So what happens in hypovolemia, that specific gravity is going to be more than 1.030, and your range is supposed to be 1.010, 10 to 30. So it's 1.010 to 1.030. That is your range. So when that patient is hypovolemic, you expect to see the urine specific gravity increase more than 1.030. The urine is going to be dark. Patient's going to be, let me back up. The reason that urine's going to be dark, that urine's going to be concentrated. Remember, guys, this patient's dehydrated. Patient's going to show confusion. That is an early sign of dehydration. One of the first things that you start to see is change in cognition, okay? Patient can go through hypovolemic shock. What is hypovolemic shock? This is when the organs start to literally shut down because it's not being perfused. No perfusion is happening. What is perfusion? Perfusion is how much those tissues are being fed, oxygen, vitamins, nutrients, minerals that's carried in the blood. Okay, so the patient is hypovolemic. They don't have enough fluids. They don't have enough blood. The tissues aren't going to be perfused. So there is a chance that patient can go through hypovolemic shock. Now, this is something very important, and NCLEX expects you to know this. If a patient is going through hypovolemic shock, those organs are starting to shut down because they're not being perfused. What are the fluids you're going to give the patient? You can give them isotonic fluids, and you have to know what those isotonic fluids are. You can give them normal saline or lactate ringers. One of the disease processes that they give often on NCLEX when it comes to hypovolemia, the situation that they'll give you is burn. because we know when a patient has a severe burn, they're at high risk for going through dehydration because all of the fluid that were in the vessels, they leak out and they go into the tissue. So the patient's at high risk for dehydration. So what do we normally give them? Lactate ringers or maybe normal saline. Okay, we give them isotonic solutions. Here's something else you can give them: albumin. Why albumin? I want you to think about this, guys. Albumin is the protein portion of blood. What does protein do? It pulls fluids back into the vascular space. So here you are, you have a patient that's dehydrated. They don't have enough fluids within the vascular space. You give them albumin, which is a type of protein, and that protein is going to pull the fluids that were in the tissues back into the vascular space. And that's why albumin is known as expanders, because as the fluid comes back into the vascular space, it does what? Expand the fluid volume. So that's important for you guys to know. All right, let's talk about hypervolemia. So we went from not having enough fluid within the vessels to having way too much fluid in the vessels. Now remember, when we're talking about hypervolemia, we're not talking about fluids in the tissue. So I don't want you to think about someone that's walking around swollen looking like this, because we're not talking about fluid in the tissues. We're talking about fluids within the vessels. So in hypervolemia, this is fluid volume excess or overload, way too much fluid within the vessels. That patient's going to have a bounding pulse. Why? That heart is trying its hardest to get rid of all that fluid, to pump out all that fluid throughout the body. So that pulse is going to be bounding because of all that fluid. Patient's going to have shortness of breath. Let me tell you something, that fluid's got to go somewhere. And if that patient has too much fluid, here goes the heart trying to pump out all of this fluids, right? The fluid's got to go somewhere. You better hope that fluid doesn't back where? Into the lungs. Does fluid ever belong in the lungs? No, now you hear crackles and you're not supposed to. So patient can have shortness of breath. They may have dyspnea, difficulty breathing. They may have crackles. That's the sound you hear when there's fluid in the lungs. There should never be fluid in the lungs. Peripheral edema, the fluid's got to go somewhere. So now you're seeing the patient's extremities being swollen. Hypertension, of course they're going to have hypertension. Remember, hypertension is the force that's being exerted against the vessel walls. If the patient has hypervolemia, they've got too much fluid in the vessel walls. Guess what? If they have too much fluid in the vessel walls, that fluid has to go somewhere. So it's going to be pushing, it's going to be exerting force against the vessel walls, and that is the blood pressure. So you're going to expect to see the blood pressure go up. The urine specific gravity is going to be low. That urine is going to be dilute. And I want you to think about it, guys. Here we have a patient that's holding on to all their fluid. Of course, the urine is going to be dilute. It's diluted because of all the fluid they're holding on to. Just like when the patient was dehydrated and they had no fluid in the vessels, that urine was what? It was full of solutes, right? It makes sense. So you guys have to know the difference and understand the difference. Don't try to memorize, guys. Understand it. So no matter how it's flipped to you, it's going to make sense. So this patient with hypervolemia, they've got way too much fluid. We're going to have them sitting in semi-Fowler's position. Why? We want that diaphragm that sits, oh, you guys can't see. Well, that diaphragm that sits right here. As you take a deep breath, the diaphragm goes down and you breathe. You take a deep breath, the diaphragm goes down, then you breathe out, it pops back up, right? You want that diaphragm not fighting against gravity. So you're going to have them sitting up so that diaphragm can go down when that patient takes a deep breath, and their lungs can expand when they take a deep breath. So that's also very important to know how you're going to position the patient. D5W. D5W, body rapidly metabolizes the dextrose and solution becomes hypotonic. Whenever you think of hyper or hypotonicity, I want you to think of the solutes. This is what they're talking about, guys. All right, let's jump down to diabetes insipidus. So diabetes insipidus, this is hyposecretion or failure to respond to ADH. ADH is antidiuretic hormone. Antidiuretic hormone is what keeps you from losing all of your fluid via urine. So if a patient has diabetes insipidus, which means they don't have enough ADH or they're not responding to ADH, guess what? They are urinating all over the place. They're getting rid of all their fluids. This patient is at high risk for what? Dehydration. So all those signs and symptoms we just talked about with hypovolemia, you're going to see it in the patient that has diabetes insipidus because of that failure to respond to ADH, or maybe there's not enough ADH to begin with. So important things you're going to see in that patient with diabetes insipidus: excessive urine output. They're urinating all over the place. Hypotension. Why? They're getting rid of all the fluids. There's nothing pushing against the vascular walls. Tachycardia. That heart rate is going up. They're losing all their fluids and the body's trying to push out blood. The body, let me be more specific, the heart is trying to push out blood and fluids to the tissues. It's just not there. Sorry guys, let me go back down. Patients going to have dilute urine because they're getting rid of all of their fluids. So the solutes that are in the urine, it's going to be diluted. It's not going to be concentrated. So you expect to see a decrease. Patient's going to have polydipsia, that's excessive thirst. They're getting rid of their all of their fluids via urine. Your body's meant to survive no matter what. So that patient's going to be thirsty because they're going to want to replace all of the fluid that they're losing. Hypernatremia. Lots of sodium where? In the blood. They're losing all of their fluids, guys, but the solutes is staying in the blood, not the urine. And that's why the urine is dilute, but the blood itself is full of the solutes. So even though this patient has diabetes insipidus, they're urinating all over the place. The urine output is huge, right? The specific gravity is next to nothing because it stayed where? In the bloodstream. Patient's going to have neurological changes. And that neurological change, guys, that directly has to do with the hypernatremia, that high sodium. Remember, sodium is supposed to be 135 to 145. This patient's sodium within the blood is going to be increased, and that is directly related to the neurological changes that we see in this patient. So what are we going to do? What's the therapeutic management? We're going to replace all of the fluids that they're losing. Remember, guys, a priority in nursing is always physiological integrity. What's keeping that patient physically alive? Fluid and electrolytes falls under physiological integrity. Without fluids and electrolytes, the patient's going to die. So one of the first things we're going to want to do is replace all of the fluids that the patient's missing, okay? We'll give them D5W if IV replacement is required. We may give them hormone replacement. What's that hormone replacement? That antidiuretic hormone that patient's losing. We may give them desmopressin, vasopressin. Now, I'm on the next page. We're going to monitor the urine output hourly and the urine, what's the SG? I'm trying to think. Something specific gravity, I'm sorry. By the way, guys, I want you to know how much I love you guys. Literally, I love you guys so much. I was living my best life watching season 2 of Bridgerton. I think I'm on, what episode am I on? Episode 7. And I couldn't even enjoy it 100% because I felt guilty that I haven't been on here doing something for you guys in a little bit. And so I paused it just to do this video for you guys real quick. That's love. All right. So you're going to want to monitor the urine output. Remember, guys, urine output should be at least 30 mLs per hour. But with this patient, they've got lots of urine that they're releasing. So what we expect to see as the patient's being treated is the urine output start to decrease, okay? We're going to report urine output of more than 200 milliliters per hour. And of course, we're going to weigh them daily. Remember, weighing them daily is the best indicator that will give us of the patient's fluid status. Not INO, not skin turgor, daily weight. All right, SIADH. SIADH is the opposite of diabetes insipidus. So remember, in diabetes insipidus, the patient was losing all their fluids. because they didn't have enough ADH. Well, in SIADH, it's the opposite. They're holding on to all their fluids. They're not releasing any of their fluids because they got way too much antidiuretic hormone. So all of the symptoms that we see with the patient of SIADH is going to be the opposite. We're going to see hyponatremia. So while they're holding on to all their fluids, right, the little bit of urine that they do let go of is going to be full of what? Sodium. So this patient is going to have hyponatremia. The sodium is going to be low in the blood, but high in the urine. Even though they're holding on to all their urine, the little bit of urine that they do let go of is going to be full of sodium, which means the specific gravity is going to be what? High. Okay. Signs and symptoms: fluid volume excess. That patient's going to have hypertension, crackles, jugular vein distension. Why? They're holding on to all their fluids. All of that fluid is pushing against the vascular space. That's bringing up the blood pressure, right? All of that fluid got to go somewhere. Eventually, it could leak over into the lungs. That's why you're hearing the crackles. I want you to think of the patient who has fluid overload. We're going to see a change in the patient's level of consciousness. They're holding on to so much fluid. They can have seizures. They can go into a coma. The specific gravity is going to be very high, more than 1.032, again, because of all that sodium that's being lost. The sodium that was supposed to be in the bloodstream is now in the urine. So be very careful, guys. Read the question and make sure you understand if it says hyper or hyponatremia, that means in the blood versus in the urine. Uremia, okay? The BUN, the hematocrit, the sodium is going to be what? Decreased. And when I say decreased, I'm talking about what, guys? In the blood. We're talking about the blood. You have to be very careful because as students, you tend to get it confused. The bloodstream and the urine are two completely different things. Therapeutic management, we're going to have that patient on the cardiac monitor. We're going to be doing frequent neurological exams because remember, they're at risk for going into seizures, going to coma, dying, right? We're going to be doing INOs on the patients. Patients are going to be on fluid restrictions. They're holding on to all of their fluids. You think they need to be drinking a glass of water? No, they're going to be on fluid restrictions. We're going to give them sodium supplements because remember, even though they're not letting go of much urine, the little bit of urine that they do let go of is full of the sodium that's supposed to be in the blood. So we're going to have to replace that sodium. Daily weights. We're going to put that patient on daily weights and we want to see them lose weight. Them losing that weight, that's letting us know they're really losing what? Fluid. Medications, we can give them hypertonic solutions. Remember I told you when you think of tonicity, I want you to think of the solutes such as what? Sodium. So I want you to think of hypertonic solutions, normal saline, D5W. They'll get diuretics such as Lasix to get rid of all of that fluid. And of course, electrolyte replacements, because it's not only sodium that can be found in the urine, there's also the other electrolytes that causes that specific gravity to be increased. Water intoxication. Signs and symptoms: drowsiness, altered mental status. One of the first signs and symptoms of fluid overload, as I said, guys, is going to be a change in the patient's mentation status, change in their cognition. Very important, guys, you must know the specific gravity. 1.010 to 1.030. I always tell my students 10 to 30. That's an easy way to remember. So when the specific gravity is high, and we're talking about the urine, it's concentrated, it's dark, that patient's what? Dehydrated. They're dehydrated, they don't have any fluid in the vessels, okay? That's that patient that has SIADH, heart failure, they're holding, let me back up because I said that's so wrong. Okay. High concentrated dark urine with a specific gravity causes dehydration, SIDH, heart failure. And I want you to think about it. I'm going to work backwards. So heart failure, guys, patient has too much fluids. The heart is unable to pump out blood to the entire body. And so what does it do? It starts to give up, right? SIADH, they're holding on to all that fluid. Correlation with the heart failure, guys. Low, the urine volume is going to be dilute. water-like. Think chronic kidney failure, diabetes insipidus, where you're getting rid of all your fluid. Remember, when in diabetes insipidus, you're getting rid of all your fluid, but the fluid's what? The specific gravity is what? Dilute. Where in SIADH, you're holding on to all your fluid, right? You're holding on to all your fluid, but what's your specific gravity going to look like? Remember, guys, those are the complete opposites. I promise you, if you can remember one, you're going to remember the other. And of course, fluid volume overload. Ooh. 1 second, guys. Okay, guys, sorry about that. I had to pick that up. Okay, guys, I'm stopping here, but on the next video, I'm going to start with Addison's, and I'm going to go over the difference between Addison's and Cushing's, complete opposites, but same thing. If you know one, you're going to know the other because they're complete opposites. So watch out for my next video on Addison's versus Cushing's. And don't forget, guys, every single Sunday, 1 p.m. Eastern Standard Time, I have a video release where I practice questions, whether you're in a nursing program or you graduated and you're practicing for NCLEX. So guys, if there's something you'd like to see me either cover with questions or do in a lesson, please let me know in the comments and be specific, because something I didn't realize, I got a lot of comments of students asking me to cover this or that, but I'm so used to only doing questions, I'll reply that this is found in this playlist or this is found in this playlist, not realizing that what you're really asking me for is like a lecture or a lesson and not questions. So if there's something you want me to cover, let me know what you want me to cover, but also let me know if you want me to cover those in like forms of questions, or if you'd actually like to see me do a teaching or a lecture on that subject. All right, guys, I'm going back to Bridgerton. Yeah, I'm going back to Bridgerton, so I'll see you guys on the next video. Bye.